Hello.
Hello. Good morning, sir.
Hi. 1 minute. You can stop the recording
Oh, okay.
and restart it later. Has he come? I can see him. Dr. Veeral?
Can you hear me?
Yes, now I can.
Okay,
Yeah.
I'm just turning it on now.
Yeah, okay.
Can you see me now?
Yes, I can see you.
How you doing?
Hi. How are you?
Good.
Good. It's morning for us. But
I'm still awake.
I know.
That's good.
Okay.
Can I start to share my screen to see?
Share it. What you have to do is first just click on the share, and then at the bottom of that window, which will pop up, there is a button which says optimize video for full screen. Check that box and then start the actual sharing.
Okay.
Just click on the share button once, then you'll see a pop-up of various options. And that screen shows what you want to share, but before that, at the bottom of the screen, you'll see a thing called optimize video. Do you see that?
Okay.
I think when you share, see, the thing is, when we share the window, immediately
Yeah.
we go on to the next thing. That means you share your desktop or you share the PowerPoint. Before you do that, check that.
Then share computer optimized for video clip. Okay.
Right, optimize for video. Correct.
All right, good. And then
Now, no problem. Yes, the video should run smoothly. Let us check.
are you seeing it now?
No, wait, yes.
Yeah.
Okay, go on to some video slide. Let us check.
Oh, I have no videos. I'm good.
Then no problem. Then no problem at all.
Okay.
We'll see it perfectly. There's no issue.
I'll have videos in the future. I just wanted to make sure that it worked. So
Yeah. So whenever you are doing a Zoom call and there is a video, you have to, before you share, you must optimize that thing.
okay.
That's all. Okay.
So can you see me?
Yeah.
Yes, we can.
As well as the PowerPoint. The problem is the speaker cannot see himself. Mansi, is there any way that the speaker can also see himself so he knows what?
I've tried seeing that, sir. I think the only option is to change your own view to gallery view, where you can see yourself.
Got it. Okay. Let me try it here, and if I can't, then we'll just.
Yes. On the top right-hand corner, there is the view, gallery view, or which view? Full screen.
Okay. Great. So
But
there's the
stop sharing your screen now.
Screen share. How's that? No, that didn't work.
Yeah, now I can see your screen, and yeah, on the right hand side, can you see there'll be something called a speaker view, or then there'll be gallery view.
Okay. Let me see it here.
Right now, while I talk, can you see a black box which says Sudhir Kotari?
No, I don't. Oh, I gotta stop sharing.
No, not there. Don't go to the menu.
Okay.
You can start your screen share again.
Okay.
And on the right hand side of your entire screen, on top, you will see timing of when the video has started or when the webinar has started. Then you will see, is it speaker view or gallery view?
But just now he's not sharing the screen, no?
Yeah, he's not sharing his screen right now.
Yeah.
You'll have to first share your screen.
Start sharing.
Okay, I'm sharing now. There you go. Okay.
Yeah.
Okay. So now on your right hand side, can you see? Not there. On the right hand side of your screen, the entire screen.
Yeah. Okay.
Can you see something called as speaker view or gallery view?
1 minute. Veeral, Let me
Yeah.
try on my phone. Let me see if I can. I see it. Then I'll tell you. Stop
Sure.
sharing. You stop sharing.
Stop sharing. Okay.
Yeah.
I see speaker view now. I see gallery view. Okay. So I
Yeah.
can.
No, but
Okay.
you have to see it while you are
Presenting.
while you're
Presenting. Yeah. Because I'd like to actually show some stuff on the board if I can. You know.
Yeah, so there is an option, right? Like right now, while I'm sharing my screen, I can see the option on the right hand side. Are you using a Windows machine or a Mac machine?
Windows.
A Windows. So on your right hand side, you should see like small.
Mansi,
Yes.
what you can do is
Yeah.
you share your screen, and then when you see that option, just take a
Take a
screenshot of
screenshot
that.
and again share it back with him. Yes, I'll do that.
Hello.
Yeah. Hey.
Hi. Mansi, what is going on? Otherwise, anyway, I mean, if you can't see yourself, it's okay. We're
Yes.
Okay, that's fine with me.
Yeah. So
okay. Now
can you like sort of, can you see the red circle and can you see something like these icons over there when you share your screen?
I share my screen. Yeah. Okay.
See, you'll probably see, can you see my cursor?
Yeah.
You can see my cursor, right? So
Yeah.
can you see something like this? Like these three small icons.
Yeah.
Or while I'm talking right now, can you see a box which says Sudhir Kothari over here?
Yes, I do. Hold on. Yeah.
Yeah, so now you can click the double the double blue box.
Yeah, I don't see a double blue box under Dr. Kortari's name at all.
You don't see that at all.
No, I don't. There's no blue box like this.
Okay, is there this small icon? This small
There's an icon that says gallery view.
no, but Mansi, just now you are sharing, no, your screen or no?
Yeah. Okay, so what we'll do is
Let him share his screen
Yeah.
and then let him see if he sees
see
that.
if yeah.
Okay.
I mean, maybe if you share your screen and then you might see this option.
Yeah, he might get the same setting on his screen. Yeah, now on your right hand side, can you see like those small three icons?
Yeah.
You can. So
Well, I don't see the same three that you show, but I see three dots here on the black bar.
no, not there, not there.
Go to the right of the
Beyond
black
that,
bar.
yeah, go to the right hand side, even further to the right of the black bar.
Full right right side of the screen completely. Yeah, somewhere
Okay.
there. Maybe above the PowerPoint. No. Let it be. Doesn't matter.
That's okay.
It's okay. We are seeing you and we are seeing the PowerPoint. You can't
All
see
right.
yourself. That's okay.
Yeah, that's fine with me.
So Mansi, I think now you open it up to
Open
the
it. Yeah,
attendee.
okay, I'll do that. So then, sir, should I start recording now? Or once, only once he starts talking?
You can start.
You let me know what. Should I start now?
Yes,
No,
you
I
can
think,
share your screen.
yeah,
We'll start at 8:30. We've got about 5 minutes more.
5 minutes more.
Okay, but it's sharing right now, right?
Yes,
You guys
it
see
is,
it?
it is.
Okay,
Yes.
good. Okay. So there. Hello?
He's not there.
Oh,
Yes.
he's not there. Okay.
Yeah. Another thing what you could do is right now I can see only your head and only like a line of your shoulders. If you can, yeah,
That
yeah.
better?
This is,
That's
yeah,
better?
this is perfect.
Okay. Okay. All right.
Hi.
So people are just logging in now? Or?
Yes.
Yeah, we have around 45 participants.
All right.
We'll give them 5 minutes more. It's breakfast time, so people must be gobbling their breakfast and trying.
Yeah. I might have to get a late night supper, actually.
Yeah, it's 11 p.m. for you, no?
Yeah, it's 11 o'clock. Yeah. Yeah. So I'm drinking coffee. Because,
Yeah, even I don't have any breakfast, so even I'm only drinking coffee.
I usually begin the day that way. Now I'm ending the day this way.
Yes. Dr. Lakshmi Narasimhan was supposed to chair, but he has been called for some ICMR duty, so he can't come. Anyway, I will be there.
And so there, if this talk, this first one takes longer than 30 minutes or 40 minutes, then we should break it up to 2 parts.
Yeah, I mean, we'll go. We have time, so you take it easy.
Yeah,
You
sure.
go at your pace.
Okay.
Chandu Tula, I'm just making you a this. Huh?
Yeah, okay. Good morning, Veeral.
Hi, good morning. Let me introduce Dr. Chandrasekhar Meshram. He's been our past president and a senior neurologist from Nagpur. So
Hello.
he will be chairing our session.
Okay, great.
Hello.
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 Good morning, Chandu.
Good morning. Do you see my video?
Not yet, no. Why is that? It shows on the thing that your video has started, but we are not seeing you.
Yeah, I'm not also able to see that.
Maybe you want to try on the phone.
No, it was fine the other day.
Try again, log off and log on again once.
Last time also he faced an issue when we had the panel discussion.
Okay. Some permission Zoom has to give his camera or something like that. Chandrasekhar, try logging off. Try logging off completely.
Okay, leave
And
meeting.
when you join, it might ask join with computer, audio, and video. So that time you have to give permission join with that.
Okay. So I will leave the meeting.
Yeah, leave the meeting. Yeah. So Asif Sheikh also, we had a similar thing. He was gulping coffee while giving the talk. But that guy, you have to tell him to sleep. I don't know what he doesn't sleep only.
Yeah. I'm probably the wrong person to tell him to sleep because I don't sleep much either. So
You too? Oh.
yeah. For a long time I would get an average of 5 hours, 6 hours of sleep. So.
Oh, okay. I should say even I sleep less, a little bit, maybe 6 hours, but there's one very nice podcast which we listened that made me think, no, I need to sleep more. I'll send you I'll send you a link for that. That guy is very
sure.
That means, in fact, I've been trying to get him to talk to us on sleep, but he's not available. So I just get through his email or anything.
The data actually shows that there is a dual-shaped curve, which for sleeping and mortality, it peaks at if you get under 5 hours of sleep, and then it peaks again at 13 hours. So if you oversleep, it's not good for you either.
Yes.
So undersleep or oversleep. So 8 hours is about right.
8 hours is too much, I don't think. But
no, that's what the study showed. It showed that 7 to 8 hours is what was healthy, but who knows? Everyone's different.
Chandrasekhar, we can't see you still, so maybe you can watch on the laptop. But when you're speaking, try on the phone.
The video is playing.
Okay, I think we've got 170 and 832. So Chandrasekhar, you want to start?
Okay, sure.
Sir, just 1 minute. Dr. Shah, we need to again adjust the angle of your laptop.
Like this?
Yes.
Yes, this is better.
Okay.
No, it's gone a bit too high. So slightly.
Okay, it's gone like it's cutting your head a little bit.
This is perfect. Now, wait. Go down slightly. Just
We're
slightly.
sorry.
Yes, stop.
Yeah.
Is that good?
There is a lag. When I say stop, it still goes. But now it's perfect.
It's perfect? Okay. So I'll start.
Meshram will just introduce you.
Yeah, hello, good morning, everyone. Welcome to this fine workshop. Today is a big day. We have 5 webinars today. 4 by fine webinars and 1 by neuro rehab. So good morning, everyone. This morning seminar we have Dr. Veeral Shah. He will speak on approach to a patient with diplopia. And Dr. Veeral is pediatric neuro-ophthalmologist, assistant professor, Department of Ophthalmology, Cincinnati Children's Hospital, University of Cincinnati. And after completing the residency in University of Pittsburgh Medical Center and Ear Institute. He did 2 ophthalmology fellowships, one in neuro-ophthalmology at University of Miami and another pediatric ophthalmology fellowship at Children's Hospital Philadelphia in Pennsylvania. So please welcome Dr. Veeral Shah. Dr. Veeral.
Veeral, you are also visiting Texas?
Yeah, no. So I was at Texas Children's Hospital for 5-6 years. There I was a consultant with MD Anderson and also a Baylor College of Medicine faculty member. And more recently, I just shifted from one children's hospital to another children's hospital. Otherwise, I do pediatric neuro-ophthalmology, but I also do adult neuro-ophthalmology. Just the only deal is all the adults have to come to the children's hospital to see me. So.
Okay, go ahead. It's
all right. So I am excited to talk to you guys. So good morning. I'm on the East Coast here in the United States, and it's 11 p.m. So I am ready to go to the disco. I've had a cup of coffee. And so we're going to talk today about diplopia. So diplo means double. Opia means vision. So diplopia means double vision. Okay. So this chief complaint or this consult that you may get, causes a lot of anxiety in ophthalmologists, because ophthalmology love the eye, love the orbit, but when they have to think about brain stuff, they get really anxious. Now, neurology, they get a bit anxious. They love all the stuff behind the orbit, but when it comes up closer to the orbit and to the eye, that's where they get a little anxious. And in this realm is where neuro-ophthalmology exists, which is the eye interaction with the central nervous system. And so I'm going to talk today to you about my favorite consult, which is double vision. And talk to you about that. Can you see my cursor?
Yeah, now I can. If it goes
Yeah.
on the slide, then we cannot.
Okay, got it. So good. And then good. So today we're going to talk about double vision. Double vision is a misalignment typically in neurology and ophthalmology of the eyes. And it really refers to something neuro-ophthalmic or neuro, okay? And so what we're gonna talk about today is the systematic approach of how to approach a patient with double vision. We're gonna talk about getting a good a good history as well as a neuro-ophthalmic exam. And then we're gonna talk about the differential diagnosis for diplopia and etiologies. So we're going to break that up into supernuclear and infranuclear etiologies. We're going to talk about single versus multiple cranial nerve palsies and sort of restrictive and orbital causes. And I'll see if we can get through all of it today. If not, I think we may have to do a second half of the talk. So a pearl, which I'm sure is common among all neurologists, and all your senior neurologists, I'm sure will tell you, that you can correctly make a diagnosis 90% of the time with a good history. So good history is so essential when you approach a patient with diplopia as a consult. But you have to ask the right questions, right? And you have to be very specific and systematic about it. So there are really 3 cardinal questions that can really help you get to the correct differential diagnosis. So the first question is the double vision or the diplopia monocular, which is one eye viewing, or binocular, which is 2 eyes viewing, okay? That is so important. And I'm going to use, I can't see myself, but I'm hoping you guys see me. I use my hands a lot, and I think we have to. In ophthalmology, neuro-ophthalmology, we use our hands a lot, especially when I talk to patients or when I have to describe things to parents or to children or patients. So if this is your eye, and you're binocular viewing at a target, which is right in front of you. If this eye is over here, will be called esotropia because the eye is crossing in.
Okay.
Yeah.
Take the camera a little lower so we see your hands more, slightly lower. The camera.
Like here.
Yes.
There?
Yes.
Okay, good. So if the eye, this right eye right here, my left eye, if this right eye is crossing in, you have esotropia, right? So it's actually foveating for a target over here, and this eye is foveating over here. That's double vision. It's seeing two items, right? Two targets, because it's not aligned. When you typically use binocular vision, you are actually fusing, so you see a single image. But with a misalignment, you're actually seeing the double vision. So that's binocular double vision. Why this is so important is you ask the patient, if you cover up one eye, they see a single vision, their double vision is gone. And if you ask them to cover the other eye, their double vision is gone. So this is very important that you ask them to actually cover their eye. You have to ask them to cover each eye, because you're trying to distinguish binocular double vision from monocular double vision. So let's say if one eye is seeing double, right? And I ask them to cover up one eye. If they happen to cover up their eye, which they're having, which is in this case, the right eye where they're seeing double, they say, oh no, my double vision is gone. You've prematurely missed out that it's a monocular double vision, and actually you're gonna go down the route that it's binocular double vision. So when you ask the patient, are you seeing double vision in one eye or both eyes? You ask them to physically, and I tell them, cover one eye. Tell me, do you see double vision? They say no. Cover the other eye. Do you see binocular? Do you see double vision? And if they say no, then that's binocular double vision. But if they cover up their one eye and they say they see two, that's binocular, monocular. That's monocular double vision. And so that takes you down ophthalmology. Okay, that takes you to an ophthalmology etiologies. You can send them to an ophthalmologist or him or her, okay? But if you see binocular double vision, that's your realm, okay? As a neurologist, as a neuro-ophthalmologist. It's a subtle point, but you really have to ask them for both eyes, because if you just do one eye, you'll go down the binocular double vision etiologies. So that's the first question, okay? The second question, and actually I'm going to take a step back. So the monocular diplopia causes, I think it's worthwhile to bring it up here, okay? Because we're not going to talk about it from here on in, because those are ophthalmology issues. And so if it's the anterior segment, if it's the front of the eye, it's the cornea. It can be, if the cornea is shaped like a cone, it's called keratoconus. That can give you signs that this is double vision. If there's opacities on the front of the cornea should be clear like a window. So if you look at a dirty window and you can see, sometimes you can see double of things in a dirty window, that's because there's opacities in the cornea, or there's dry eyes, which can actually cause you to have that double vision. And that's a very common thing that I see, especially in our young kids and adults, because now we're all in front of the computer and everything is on the iPhone now, or the iPad, or and we're texting and we're not blinking as much, and we're engaged into viewing the luminescence behind each of the screens that we're looking at. Cataracts. So if you happen to have a cataract, that's again an eye issue. That's an ophthalmology issue. That can cause you to have monocular double vision. After having cataract surgery, whether it is inflammation from the cataract surgery or the placement of the lens itself, can cause you to have monocular double vision. And finally, in the back of the eye, you can have the retina abnormalities. You can have retina abnormalities in terms of a hemorrhage or fibrosis, or epiretinal membrane, which is a type of fibrosis, which can distort the retina to give you a symptom of monocular double vision. And really rare, you can have cortical diplopia, which is something higher up that can cause you to see multiple objects of multiple times over, more than two typically. But those are all monocular double vision causes. So those are all ophthalmology, of course, and the cortical diplopia is really rare. It's very rare to get. So the first question you've already figured out: monocular versus binocular diplopia. Monocular, ophthalmology, okay? Now we're talking about binocular diplopia, right? So the next question to ask is, are you seeing it horizontal, vertical, or oblique? And I have pictures here of a mountain to describe what horizontal, what vertical is, and oblique means it's slanted. So there's a horizontal and a vertical component. So that's very important to ask these questions, because this in particular helps you hone in on your etiologies of what you're thinking, your differential diagnosis. So I'm going to show you the next screen because I think it's really important to put these thoughts in your mind early when you start to evaluate a patient. So when you talk about side by side, and so I use my hands, like I said. So when I talk to a patient, I say, hey, are you seeing two of things, side by side? Are you seeing it up or down? Are you seeing it like oblique or slanted? And those are really important because they don't know. I mean, they just know they see two of two things, but they when they look really closely and you give them examples, you let them know. And I also use my hands to say, when you're figuring out, and that's going to go to the next question, is it getting worse or better? You can tell what worse is further apart, better is closer together because they're fusing the objects. So horizontal, if you tell me that it's horizontal, they said, no, I don't see anything vertical, it's horizontal. Well, then you start to think and you start honing down your differential. So you start to think sixth nerve palsy. Sixth nerve palsy, why? Because you have 12 cranial nerves that come from the back of your neck that go forward. 3 of them go towards the orbit to move the eye, right? So it's the 3rd, the 4th, and the 6th cranial nerve. The 6th is the lateral rectus, right? So it's horizontal movement, right? 3rd also innervates both vertical and horizontal muscles, right? So the 3rd can be involved. And then there are other issues that you can have, which are higher up about fusional issues called convergence insufficiency, divergence insufficiency. There are supranuclear causes like internuclear ophthalmoplegia. I know my audience, so I know you've heard of all of these. Myasthenia gravis, and something we call a decompensated strabismus. Now, when you start to tell me that it's vertical, right, then you have to start thinking about what cranial nerves affect the vertical muscles. So we already know 3rd does, because we know that it does both. 4th is specific because it's superior oblique, it's involved in torsional muscles, so it has a vertical component. We know that when you disrupt the vestibular inputs, that can cause you to have skew deviation. And we know that thyroid eye disease and myasthenia can also be involved in causing vertical misalignments. And thyroid should be on this list too, because it can definitely causes horizontal diplopia as well. So finally, the 3rd question, because it's just make it simple. First, it's monocular, binocular. Describe if it's horizontal, vertical, or oblique. And the 3rd one is, I call it directionality, because I want to know when you're having double vision in which position. So is it in a particular gaze? Is it worse when you look straight to the left or to the right? That's what I mean by gaze. And then the other component to that is it worse at near versus distance? Okay. And then is it constant or intermittent? And I think the first 2 questions get to the point, is it constant or intermittent? And I think it's really important, and that's all about the direction of it. So for example, a 6th nerve palsy, which is an abducens nerve coming from the pons that is projecting forward, and end point is the muscle, extraocular muscle, which is the lateral rectus. If there's a dysfunction of the lateral rectus in my right eye, then the eye is going to turn in. Everything okay? Yeah. All right. So then the eye is inward, right? So what happens when you read something up close? When you read something up close, your eyes converge, right? So when you look far away, just to keep that target on, you're going to move outward. So if you ask a person who has a mild 6th nerve palsy with the eye sitting inward, they're not going to have any double vision up close. But when they look far away and they're unable to move that eye out to keep it, they're going to start to have double vision. So many of them with a mild 6th will say, near, I'm not noticing anything, but afar I will. So now that gets to, is it constant or intermittent, right? Because intermittently, if they're looking up close and doing near work, they're not noticing it, but occasionally they're noticing double vision, but it's far. And they may not recognize that insight that it's near or distance, but you need to ask that question. So it's about directionality. Is it worse at near, distance, and then gaze? So if the eye is in like this for a 6th nerve palsy on the right-hand side, then if I look to the left, they might not have double vision. kids will actually turn their heads to the right to preserve binocular vision, and so that they can see, and they'll have no issues, but they'll have their head turned, and that's what people notice, and that's why their parents bring them in. Now, straight ahead, up close, they're going to say, no, their alignment is pretty good, and they'll probably have a very small deviation. However, when they look in the right gaze, this eye is not going out. There's a huge deviation in their alignment. Okay? So that's what we're asking about directionality, is gaze, near and distance, and then that gets to, is it constant versus intermittent? Okay, constant versus intermittent means constant. Are they seeing it near and distance? Then that's constant, and it's constant all the time. That's great. But if they're saying it's intermittent, you start to think about other etiologies like myasthenia, and is there a fatigue level, and thyroid eye disease, and we'll talk about that a little bit later. So the next thing is medical history, because that's really important. Now, trauma is huge. Trauma, not only acutely, because acutely, if they got hit in the back of the head, you're worried about cranial nerve palsies, you're worried about hemorrhages that are potentially causing herniation and causing cranial nerve palsies. You're worried about multiple cranial nerve palsies if you're concerned about acute trauma. Remote history is also very important. So we'll talk about the pathway, about the cranial nerve, fourth cranial nerve, which takes one of the longest routes of the cranial nerves, and it's very prone to getting injured in trauma. And so with head trauma, and that can actually happen remotely many years, even in childhood, and they've been compensating for some time, but then they decompensate. You know, with time and age, as you get wiser, I like to tell people, you lose some of that fusional component, and you may decompensate a strabismus that's there, like a fourth nerve palsy that's decompensated. So knowing that history, they got hit on the left-hand side, or they had an injury on got hit on the left part of their head, that can come to play. So getting that history is very important. Congenital and family history is very important. So certain genes, obviously, certain types of syndromes can follow one another. Congenital-wise abnormalities in the abducens nerve can cause Duane syndrome. So it's a hypoplastic abducens nuclei, which can also lead to misinnervation and going into the third, going into the pathway of the third cranial nerve. There's also Mobius syndrome, which you have like an abnormal sixth and a seventh a nerve palsy, and so those are things that are very important to know as well. History of strabismus surgery is huge, and so is knowing if there's amblyopia, because for example, if you have dense amblyopia in one eye and you can't see well in that eye, and then you're coming in with double vision, you really have one good eye that you're using. So if you're 20/20 and 2400, they're coming with double vision, it's presumably monocular double vision, because you really need good vision that is competitive with each other to really appreciate that double vision. And cataract surgery, which we'll come to, is very important to know, especially if their double vision symptoms add up temporally post cataract surgery. There's several reasons why you can have double vision after cataract surgery. And then systemic diseases are huge, as you know about history. So thyroid eye disease, autoimmune disease, knowing that they have other autoimmune disease is very important. Thyroid and myasthenia run hand in hand at times. Vascular disease, any vasculopathic disease is very important to understand. History, even remote history of cancer and treatment, meaning radiation, chemotherapy, or even debulking surgery, are all important. And the concern mainly in that is metastatic or transformation in terms of cancer. So neuro-opt exam, the first and most important thing is inspection. When the patient comes in, child or adult, first thing you're looking at when I know that it's coming in for double vision is what are they doing? Now, children tend to compensate, so do adults. When it's an acute issue, you want to look at their head position. You want to look at how are their eyes are aligned when they walk in, how are they moving when they're walking in terms of their head and neck position. So those are all very important because they could be compensating, and their actual misalignment may be deceiving to you until you straighten up their head. Visual acuity. So vision is essential part of ophthalmology. Neuro-ophthalmology, it's key. What neurologists that I've seen have made any mistakes about vision, and that's why I always emphasize this point, is that vision is acuity plus the field, okay? So you can get a near card and put it in front of a person, they can read it, but it doesn't say anything about their field, right? So vision, your vision is how sharply you see something, but also how much. Because you could lose all this vision and you could look through a straw and see 20/20, but you've just lost all this vision, right? So both neuro-ophthalmology, a big thing for us is to look at the visual acuity, but also the field. And so we're doing fields, confrontational visual field in children. We're doing visual fields in children who can cooperate with it. But you can get a very accurate idea of pathology by doing visual field in neuro-ophthalmology. And so, and then the next is the pupil exam. Pupil for us, we always check it before some of the other ophthalmologists because they like to just go ahead and dilate and get to the back of the eye, get your glasses or look at your retina. But pupils are huge because pupils tell us so much about, and in this case, it'll be about third nerve palsies, about traumatic mydriasis, if there's trauma to that eye, especially if they're unconscious or not conscious. And then it also tells us about if they have actually vision issues that are related to the optic nerve or macular papular bundle damage. Now, at the heart of this this talk is motility. So a lot of our brain, human beings are visual beings. You know, vision is key from the beginning. 1 for survival, 2 for learning, 3 for just the full fulfillment of life. And so not only is the afferent pathway, which you all know, which is vision from the retina, optic nerve, chiasm, LGN, back to the optic radiations, back to the occipital lobe, and then the processing of all of that, which how much of our brain is involved with that. But there's also a huge amount of our brain that's dedicated to the ocular motor control of the eyes. And so it's not only one eye needs to be coordinated, the right eye be coordinated with the left eye. It's so complex, right? To stay still, to be coordinated, but it has to be coordinated to the head, to the neck, to the torso. And now if you're running, think about all of that. And it's taking all that information to maintain stability of your visual field and keep things fused, right? So motility is huge, right? So for diplopia in particular, you want to know about alignment and its motility. And motility can be broken up into 2 things: ductions and versions. Okay, I always had to think about things to remember, things versus ductions and versions. But duck is a single; it's by itself. When a bunch of ducks come together, they make a V when they fly, right? So duck means one eye, so it's looking at right, left, up. It's looking at the motility of one eye. Versions is looking at both eyes moving together. Okay. The other part of the motility exam that I do is the saccades, pursuits, vestibular ocular reflex. So saccades, we're looking at fast eye movements. So usually I have them look straight ahead of my nose, and I quickly put a hand up to the right, left, down, up, and below, because you can test your vertical saccades. But you're playing a guessing game, and you're having them see how fast they can move to their move and look over to see your hand. I usually say hand, back, nose, hand, nose, hand, nose, hand, nose, hand, nose. So that's you want to move quick, right? That's what you're really figuring out. It's the fast eye movements. Pursuits is slow, and it should be smooth, and it should be nice tracking of both eyes in conjunction together. If there's any pathology, there's either a delay between both eyes, or there is a cogwheeling, sort of. It's not a smooth movement, okay? So of the eyes, if you see pathology. And for this talk, for double vision, vestibular ocular reflex is very important. And so that's usually having the patient look straight forward and have them look at a target, and you're moving their head, and you're looking for stability of their eyes. If they start to move with the head, there's something, there's clearly something wrong with their vestibular inputs with their vision. Okay. So then ocular misalignment. So ocular misalignment is referring to the alignment of one eye in relation to the other eye. Okay. And so I'm going to talk about that in a moment. It's the next slide for me. But and then forced ductions, which is if there are some abnormalities with the eyes. I don't do forced ductions as part of the normal exam. Forced duction really means an eye that's is not moving in a particular direction. If you're worried that there's a restrictive process, there's something that's not allowing it to move. The muscle wants to move, the nerve wants to move. There's something there, either growth, the muscle is thickened, it's fibrosed. There's something that's causing it to move stiffly. It's not the firing of the nerve. You can actually try to move it physically. Okay, that you need numbing drops, and sometimes with kids you have to be under sedation for that. So ocular misalignment. This is really important. So as a neurologist, you can, if you have a muscle light or light right in front of them, you're having them look at the light. And what you're looking at is a corneal reflex and reflection. An eye that is fusing and looking right at the light, it'll be right in the center of the pupil. An eye that's deviated inward, you know that corneal reflex is going to be out laterally, okay, or temporally, okay. And then that's an ET. An eye that's XT obviously will be more nasal, and the other eye that's fixating on it will be right in the center. Okay, so that's how you can tell about the misalignment. Now, the way we look at misalignment is a cover on cover. If you just want to look at what they call a tropia, which is the esotropia or the exotropia, what you can do is put just one occluder and then move it, and then move it on and move it. And you're going to see the movement as you do cover on one eye, and you can do it to the other eye to see where it naturally sits when it's not viewing. That's the tropia. The alternating cover test that's mentioned here is actually moving back and forth, and you're actually breaking the fusion aspect of it. So if we all look at one of each other's eyes when we go to bed, what happens? If you lift up the eyes of anybody who's sleeping, you'll see that the eyes are out. When you're sleeping, your eyes are out because your orbit is out like this, and your medial, and so it wants to sit out. When you wake up, you start to fuse, and both eyes are working together, okay? It's fusing actively, right? When you get tired looking at a screen for a long period of time, you start to cross a little bit, you need to take a break. You're rubbing your eyes, you take a break, and everything's better. Because if you're fusing and you're over-exhausting and you're fatigued, and you're converging for a long period of time, your body needs a break, right? The muscles need a break because you're overly fusing, and that's why you're crossing. There are many things that can disrupt that fusion. Being sick can disrupt that fusion. So there are several things that we'll talk about that can disrupt the normal fusion that you get with both eyes, okay? And so this Maddox rod is a filter that you put over in one of the eyes. And what it does is that you shine a bright light in front of it, and it makes a corresponding line. And so one eye is actually viewing the light, and the other one is viewing the line. And what you can do, and what we do in ophthalmology and neuro-ophthalmology is we have prisms on a bar like this, and we put those prisms to bend the light in the way that they're graded. The prism is actually increasing in size, and it can bend. So depending on the deviation, we're bending the light where the patient says they're actually fusing. And once we have them fusing like this, they say the line is right over the white light. So this one's staring right at it, and now we've adjusted the prism so that this has gone from here to right on that white line. We know that's exactly the amount of the deviation that they have, and that's how we measure the deviation. This you can measure in both hypertropia, if the eye is above, one eye is above or below, or in terms of esotropia, exotropia, and that's what these designations. XT is exotropia. This is talking about a left hyper, so the left eye is a little bit sitting higher than the right eye. This is just an example to show you. I just wanted to talk about it because it's something that comes up with us in neuro-ophthalmology is double Maddox rod, which is to measure torsion. So one of the muscles that I've talked to you about was the fourth cranial nerve, which innervates the superior oblique muscle. That's involved with torsion. That's involved with vertical muscles. And so if you have a disruption in, if you have a fourth nerve palsy, then you're really going to have some torsional issues. And so this is a way to measure the amount of torsion that may be causing your misalignment. So what you're doing here is you're wearing these glasses, and in one you have a filter of a red, and the other one you have a filter of a white, and there's a bright light out here. And what you're making is two lines, and obviously one is torsionally off, and that's why the line, you see a line, but it's not parallel. And so what you can do is you can dial this, because this is the red filter, for example, you can dial this and turn it to figure out the degree of torsion. And usually when you have a single fourth nerve palsy, you have anywhere from a 0 to 10 degrees. Usually it's about greater than 5 degrees of torsion. When you have bilateral fourth nerve palsies, it can be greater than 20 degrees of torsion, and you can do that separately for each eye. In terms, that's adding up each eye. A couple more things I want to talk about in terms of understanding misalignment, and I think this helps with thinking about the etiology, is comitant or concomitant versus incomitant. So concomitant deviation is the angle of deviation that are the same in all fields of gaze. So I'm going to show you an example on the next slide. But it usually refers to something that's been chronic or congenital. Incomitant, which is what we're going to see, which is the main thing that we see with a double vision complaint, is that the deviation, the angle of deviation is different per gaze. So I'm going to start with talking about the incomitant misalignment first. So right here, if you look at this female, she's straight on when she looks in primary. Primary is right in front of you, okay? When she looks to her right, she's fine. She has no double vision when she looks in her right gaze. However, in her left gaze, she's seeing significant double vision. And that's because the deviation has changed. So she may have a little bit of a deviation here, really nothing over here, but then has a large deviation here. So the deviation is changing dependent on the gaze, okay? And that usually occurs in an acquired or an acute setting for double vision. On the contrary, this patient, you can already see has a large exotropia here. This eye is shifted out, the left eye. When he looks to the right, this is looking to the right. This one makes it, but this one doesn't. Even though it looks like it's centered, it's not, right? Because it's lagging. It should be all the way over to the right. And when it looks to the left, there's still exotropia. So there's exotropia here, exotropia here, exotropia here. So you can see that it's in all gazes, the deviation is there. And so that typically tells you something that it's been there for a long time, or presumably congenital in etiology. Now, if you let this acute sixth nerve palsy go on for time, it will actually, with time, with chronicity, will become comitant. So you'll have that deviation and creep on in different gazes as well. So we're going to talk now about the etiologies of double vision. I think at this time, I'm just going to talk about supranuclear palsies. Then we'll go into nuclear and infranuclear causes, and then orbital causes. So supranuclear palsies, that's above the nuclei before the cranial nerves. And so the one I'm going to talk to you about a couple of them. And I think the most common ones are the ones I'm going to talk to you about. So skew deviation, what is skew? Skew means slant, right? Things are slanted, okay? And so they're talking about when these patients come in with skew deviation, they're talking about seeing a vertical or an oblique misalignment, typically. They're also very clear that they have balance issues. They feel like they have vestibular issues that they're talking about. And skew deviation is a vertical misalignment that has to do with asymmetric disruption of central inputs involving the vestibular system, and really caused by peripheral and central vestibular lesions. So you can have lesions anywhere from the thalamus to the brainstem, but mainly it is posterior fossa in nature. Any deviations in children, with adults with posterior fossa tumors, they're having, they can have some degree of vestibular vestibular issues. They're having skew deviation, and they'll talk to you about a vertical diplopia. Now, exam-wise, it's very difficult. It can present in many different ways. They can have nystagmus. There are two sort of clinical pictures that we see that can help you really describe the vertical misalignment that they have. So one is an alternating skew deviation. So that's when you have them look to the right, you'll see a right hypertropia. And when you have them look to the left, you'll see a left hypertropia. And that gives you a clue that what you're dealing with, especially if they're describing a vertical misalignment of their eyes. Another issue, and that alludes to vestibular issues. And the next slide I'm going to show you talks to you about what many of them describe in their vestibular complaints, is an ocular tilt reaction. So typically, when you turn your head to your right like this, as you show in this picture here, your eyes are going to roll both eyes are going to roll to the higher ear lid that's at the higher length. So in this case, this picture here is showing this rolling in the direction of this higher ear. However, pathologically, if they have abnormal vestibular inputs, you're actually going to see a counter roll to the lower eye in terms of relation. So what you're going to see, they should be rolling up this way, but they're actually rolling downward to the lower ear. And so that's an ocular tilt reaction as described. That also can be described with skew deviation. But this list here summarizes other features that they describe when they talk about their vertical misalignment. So they're describing dizziness, vertigo, oscillopsia, nausea, and vomiting, mainly because the brainstem is also involved, dysarthria, dysphagia, clumsiness or poor coordination, balance and gait issues. Clinically, what you can see is saccadic dysmetria. You can see breakdown in their smooth pursuits. They have nystagmus is quite common. If you really look closely, you can see a vertical or nystagmus that comes in, or torsional nystagmus that comes in. And clearly they have ataxia issues. So another common one I'm sure you guys are very familiar with is internuclear ophthalmoplegia. That is disruption of the medial longitudinal fasciculus, which is in the pons and midbrain region. You can see here, the example that I give here is that the MLF, this is lined up to show it. They have a difficulty in their, as shown in this picture here, with adduction. So you see a adduction deficit, and in the gaze that they're doing the adduction deficit, so in the left gaze, you see a nystagmus in the contralateral eye. Now, the one thing that's really important, and I know you guys know this particular one pretty well, is that you can test for this because they should have, even though they can't do this movement because there's a disruption in the MLF, they should still have vergence intact. So if you actually are seeing an adduction deficit and you're seeing a nystagmus. Now the nystagmus on the other may or may not be there. I mean, it's, you know, I've seen plenty of INOs where it's not the classical. We all like to describe the classical relationship with the nystagmus on the left, in this case, on the left eye, as you're looking in the left gaze, and if the right MLF is affected, then I'm having an adduction deficit. This eye makes it over, but there's a beating left nystagmus. You may or may not see that, but what you can see is that if you bring something up close and you ask them to converge, this will actually adduct in. And so that's a very important thing to test when you do your clinical exam. Now, the most common causes are either demyelinating, which is probably more dominant over microvascular issues. I thought I would just describe the 1.5 syndrome, which is a disruption of the medial longitudinal fasciculus, as well as the paramedian reticular, the reticular formation. And what you see here is that you actually have, so this is a much larger either infarct or demyelination, where you're not only disrupting the MLF, but you're getting the MLF, potentially the abducens nucleus, or the paramedian pontine reticular formation. So this actually would then cause you to have, in this picture, so this is describing on the right side, this is describing what would happen on the left side, which is you would have difficulty with sort of an ophthalmic plegic eye because you're having trouble with adduction. Your sixth is involved, so you're having trouble with abduction, and you're having adduction issues with the MLF as well. So you have no adduction, bilateral no adduction, no abduction, and on the side affected, and then you just have your lateral rectus, the sixth on the left side that's unaffected. So they call that 1.5 syndrome. So the other two ones that I think are very common are convergence insufficiency. So this is now a horizontal double vision. It is greater at near than distance, and that's completely opposite from what we talked about cranial nerve sixth nerve cranial palsy, because that we talked about you're having trouble. The eye is sitting in an ET position. You're seeing things fine up close, but you're having trouble bringing that eye out, right? Because of the sixth nerve palsy. Convergence insufficiency is actually the opposite. They're having trouble converging their eyes, so they're seeing double at near. The most common reason we see this that I see is concussions, and we see this quite often. I see it in both male, female. Many times it's hits to the heads. I've seen it many times in gymnasts who just have bad landings as young children who land and hit the back of their head, and they're having trouble focusing. They'll clearly have issues converging close with it, and so it's more of a shock to their fusional system, and it takes some time. Now, the worst thing is when they get repeated concussions, because you only have so much compliance in your fusional ability. The way we make this diagnosis is that we sort of ask them as they come close, because they don't have problems at distance. It's converging that they have a problem with. Looking at things far, they have no symptoms. So the double vision starts as things get closer. So if as you bring your finger in, you ask them when do they see the double, and then you measure it from the tip of their nose to where they're seeing double up close. So these are ones that I would look at students who are very myopic, who are studious. So high myopes that are studious, they can also get this. Trauma is the most common reason to get this. And if they have an exophoria, which is if you break their fusion, their eyes drift out a little bit, they can also get this convergence insufficiency. The way we treat this, and the easiest thing to do, is actually what we call pencil push-ups. So you take a pencil or anything, but usually we just, it's called pencil push-ups. So you get a pencil with a eraser at the end, and you have them bring it far where they're not double, and then you bring it in close, and they're actually just working their muscles. This is the one situation where vision therapy, in terms of exercising their muscles, help and actually improve their situation. So after doing this for about 3 to 4 weeks, they'll actually recover. I mean, even my concussion patients, they will recover pretty quickly. It's only concerning when you have repeated concussions where they've really lost that compliance to bring it to fuse back. When they have this issue, you can be aided by prisms. I tend not to like to use prisms. I really want them to be forced into convergence. There's also computer programs that you can use that can help them and converge as they're doing it, and so that's a newer trend. And when they're not, I think a repeated concussion patient, when they're not able to converge, what we end up doing is strabismus surgery, but that's rare. I would do all the conservative measures first before we even talk about that. And worth talking about is divergent insufficiency. So that's actually inability to go out. So the main thing about this is it mirrors a sixth nerve palsy. So you better rule out a sixth nerve palsy and have a complete workup. This is like this is a diagnosis of exclusion. It can mimic many things. So if you're having trouble diverging your eyes, you may think that you have a bilateral sixth, might be high pressures in the head. You're worried about a brainstem lesion. Most commonly, this happens to elderly people that are vasculopathic, but you do an MRI, you don't find anything, and they really have full motilities of their sixth. So it's just a decrease centrally in their compliance to diverge their eyes. Typically, it's a small deviation, and you end up you can treat them with prisms. You can also treat them with strabismus surgery if the deviation is large enough. So there, I think about 50 minutes.
Yeah.
I think maybe I could take questions now, and then I think the next half I might have to do it around 2 for the next one, because I think it'll take another 40 minutes.
Yeah, so we'll do that next time.
Okay.
You can take the questions.
Sure.
Chandrasekhar, you want to ask the questions?
Yeah.
While he's checking them up, we sometimes see patients with, sometimes they go for a cataract surgery or they have some other problem, and then come back complaining of diplopia. And then when you check them, they have actually a concomitant squint, but it's like got decompensated, like sort of. So
decompensated, yeah. So the important question, actually, it goes into my next talk, because I have 3 or 4 slides about describing why cataract surgery can cause double vision. But the concern there many times is if they got a nerve block and how they got there. Many times they put the anesthetic below the eye, underneath the eye, and they inject it into the basically the cone of the back of the eye to numb all the sensation, so the eye can't move. So it's actually frozen, right? And so they can do the strabismus. I mean, they can do the cataract surgery while the eye is frozen, so the patient doesn't move and can't move the eye. So there's stability. Sometimes in that injection, it can actually disrupt some of the muscles, and also if it's injected right into the nerve, it can be neurotoxic. I'm only speaking. I think there are 4 or 5 other reasons why cataract surgery can cause double vision. Saying that, I think cataract surgery is probably one of the safest surgeries to get done. So I'm not against it, but we have seen reasons why people get double vision from cataract surgery, and that's one of several reasons why you can get it.
Okay.
Yeah, what do you mean by versions in eye examination?
Oh, version means both eye movement. So sometimes when you want to look at a gaze palsy versus the individual eye movement, version is when you look at versions, you're looking at both eyes moving together. Can you guys see me or no?
Yes, yes, we are seeing.
Okay. Okay. So versions is, so when I say look to the right, look to the left, you're looking at the alignment of both eyes together in relation together. That's version. So that's both eyes together. Duction is covering one eye, saying look all the way to the right, look all the way to the left, look all the way to the below and up. And the reason why that's important is because if you have a specific gaze palsy, that's going to affect the gaze, but not the individual motility of each eye, right? You're in this, I'm not thinking about versions or anything. I'm just looking at the full-on set of that eye moving right, left, up, and down. So you can get very different movement if you look at it one eye specifically, which is deductions, or binocular with both eyes moving together is divergence.
Yeah, then another question is, eye examinations should start with individual first and later both eyes, or?
Say that again? I'm sorry.
Eye examinations should start with one eye and later both eyes.
Do you start with one eye and then the second eye, or you start with both eyes first and check individual eyes?
I do both eyes first and I check the individual eye. Actually, you know, I take that back. What I do is I actually check deductions first and then do version second. The reason I do that is because I don't trust people. I'm a neuro-ophthalmologist, so I don't trust the complicated cases I see. I don't trust them. So I always patch the eye. So I patch the eye when I check their vision. I patch one eye, right? Because I want to know. I don't want them to cheat with the other eye. If you put an occluder on, kids will turn their head and they don't know. So I've had adults say, I think I can see it, and they're using their other eye to actually see it. And it's like, there's no way they can use that eye. So I don't trust them. So I get in the habit, adults, children, I patch one eye, I check the visual acuity, I check their field, I check their color vision, and I check their motility at that time. Then I switch eyes. We always do in just tradition, we do right eye first, left eye second. And then left eye, I check all of that. And then after they're done that, I check with the muscle light, I check their versions, and then I check their pupils, because that's when I can compare the both pupils together. And I always do that before I dilate. So, but when I take that patch off, that's when I check versions, I check their saccades, I check their smooth pursuit and their vestibulo-ocular reflex, because I need both eyes now at that point. And I check their alignment at that point.
Yeah, Deepak Arjundas has asked whether you check color vision routinely before neuro-ophthalmologic examination. Color vision.
I do. Every patient gets color vision for me. Okay. It's very important. What was that?
No, go ahead.
Yeah, it's very important. It not only tells you, I can't tell you how many times I've diagnosed congenital dyschromatopsia, and they never knew, so it helps you with that. I can tell you how many times it clarifies congenital issues versus acquired issues, because congenital issues, you don't get color vision issues, okay? But acquired issues where you have optic nerve pallor and you're trying to figure out, was this from a congenital issue versus an acquired issue, you're gonna get that dyschromatopsia. And obviously, if I think it's I also do electrophysiology. And I have that training as well. So if I really think it's a retinal issue, I can do the FD15, the Farnsworth 15 test. But I think for neuro-ophthalmology, we're talking about the Ishihara plates, which are red and green. And the reason that they're not the whole spectrum of all the colors, right? If you look at those, they're mainly different shades of red and green. Is what it is. Each one of those is mainly red and green. And the reason for that is it's made to identify optic nerve disease, because optic nerve disease drop off is seen with the Ishihara plates. And that's the main power of the Ishihara plates.
I wanted to ask, these Ishihara plates are available on certain apps in the phone. Are they okay to just screen?
Yeah, that's a good question. I think for screening purposes, it's perfect. There's an eye handbook app, I think that's commonly we use. I think now with telemedicine, we've been using it more than we normally would. But I think that's fine. That's perfect. I mean, it picks up.
Which is the app you suggest?
It's eye handbook app.
Okay.
Yeah. Let's see here. I have it. I can show it. It's called eye handbook app. That's exactly it. It's eye handbook. Yeah. EHB. That's what you'll see. So.
Yeah. Someone has asked any app for visual acuity and color vision in OPD.
Yeah, that's what the eye handbook.
Yeah. For color vision eye handbook, there have been 2 or 3 papers that are trying to distinguish if the color vision on the app, the luminosity makes a difference from the Ishihara plates. And I think that paper didn't really show a significant difference. I think for screening purposes, it's perfect.
Deepak has asked what special test to assess rod and cone function.
Oh, rod and cone function. What test? Like electrophysiology wise?
Yeah.
Yeah. Oh, so you know, so rod and cone. When I see when I have a child come in with low vision, and they want me to figure out what's going on, I check. I get their history. Rods and cones are very different. If it's cone and rod disease together, they're very similar. But you get their history. Color vision, they're going to have low visual acuity. They're going to have typically nystagmus if they're a young child. And they will have poor Ishihara plates, like really poor, right? So you can, if you want to really distinguish that, you can do a FD15, which is a Farnsworth D15 screening test, which will pick out certain types of cone deficiencies. But for electrophysiology, I do a full field, right? And so you do a scotopic, photopic, full field ERG. That's going to tell you what you need to know in terms of rod and cone disease. And that what that is it's an electrode that you put on the eye right here, and there's a ground. It flash lights. Now they do it in two phases. If I'm saying anything that you guys already know, I apologize. But they flash lights. They test you in the dark, and and that's the scotopic. And then there's a photopic. Now the scotopic tests the functionality of your rods. The photopic is testing your color, your cones, right? Because they pick up bright light. Now what happens is there's something called dark adaptation. So your cones are really good at good lighting, but when it starts to get dark, your rods kick in, okay? Because your rods actually allow you to see better in the dark. And many kids who have a rod dystrophy have night blindness, but they're 20/20, or they have very good vision because their cones work really well, right? But they just have night blindness. So in that history, you want to find out if they have night blindness or they have photosensitivity to light. Photosensitivity to light tells me that's a cone dystrophy more likely, because they're very sensitive to light. They can't handle that light, and they have poor vision and they have poor color vision, because that's what the cones do. They give you sharp acuity, and they give you color vision. And when you don't have that, you only have rod vision. And when you have rod vision, that's poor vision, because rod vision doesn't equal 20/20 at night. It's just, it's poor vision. So they end up having 20/100. They have good vision and stable if it's just a pure rod or cone difference. But many times they're a combination of both. And that's typically the case because we're finding out that there are many genes involved with obviously the rod and cone and seeing vision. And so If they're compounded or they affect the cascade, they're affecting both rod and cone, depending where the message is going back.
So how do you clinically, what are the clinical tests for this? So one thing you said from the history, you might suspect that it's a rod or a cone disorder. When do you try to think from history that this could be either a rod or a cone disorder, and then how do you distinguish? And are there any bedside tests that can help you flashing the light and seeing how long it lasts, and that after image, there's something like that, or it's too...
Oh, that's what I call the after image test. You can do that's an after image test. So first is the history, then it's stick to your the neuro-op exam. So get the history. Is there any family history of poor vision? Is there any other anybody in the family that has low vision at an early point? That's the first thing. Many times you find out that's negative, okay? Because what you see is that the mutation is de novo, started with this child, and I see a lot of this. So started with this child or with this person, because there's no family history, okay? And so when that case is there's no family history, then you do your exam. And in your exam, what I can see is this. If it happened young and it was severe, they have nystagmus, okay? So that's pretty clear. If it's profound in terms of cone dystrophy, they all have nystagmus really early, and they're sensitive to light. So they're doing this. I mean, they can't open when it's bright outside. They won't be able to open up their eyes, and that's a really clear history. Then when you check their vision, it's subnormal. Like I said, the cone vision allows you to see 20/20. So if your cone is affected, you're not getting anywhere close to that sharp vision. So their vision on average is 20/100, 20/200. It's really poor. Okay, and then
pale? Do they have disc pallor also secondary?
They surprisingly they'll have is temporal pallor, but not the whole nerve. And temporal pallor, why? Because the cone, highest concentration of cones is in the center of the maculopapular bundle. So they'll have actually, if you on exam, it might look completely normal in terms of the retina, the macula. The optic nerve may or may not show temporal wedge, which is irrespective of the maculopapular bundle. And if you do a particular image of the retina called autofluorescence, it's going to pick up a ring, typically. And that ring is showing basically byproduct because it's missing cone. Okay, and so it's malfunctioning, and there's some byproduct that's left over that you can show. So that's a common thing. It doesn't happen to all of them because there are many different types of cones, but commonly with that you'll see that. But the clear indication is bilateral disease, both eyes, not one eye. Bilateral vision is poor in both eyes. Color vision is poor in both eyes. That's a cone. Now, if they're telling me that they prefer the night, they prefer seeing things or doing things at night, then that also goes along with the cone disease. Now, if they say the vice versa, that when it's a little bit cloudy outside or it's dark, it's like it's blinding to them. When most people are like, you can still see in the dark, I can move around my room. That's night blindness. And they tend to have very good vision, but they have trouble with at night. And so the history is very important. Asking these questions, if it's a child, then you're asking the parents. The parents will know immediately that when their kid goes to the playground, every other kid is playing, but their eyes they don't like the bright light. They're coming in, rubbing their eyes and not liking the light. If it's at night, they'll say, yeah, when it's dark, they'll cry because they're scared. And it's a cloudy day, just a cloudy day, because that's a little bit less light. They feel like it's dark, like it's midnight, when it's a cloudy day. And that's very much clear that that's night blindness, okay? So the history helps you out a lot. So cones, again, severe vision loss early. The reason why we have nystagmus, why do we have nystagmus? Well, nystagmus is probably a reflex that we've had naturally, in which when there's a dearth of sensory information coming into the brain is hungry for information and developmentally. So it kicks in a reflex to seek for light. and it's a rhythmicity and sensory that just ongoing, and it's actually an adaptive feature, which it kicks in looking for light, and it just sticks with you because it doesn't get that sensory information. So when the cones are not giving you, and the cortical brain, developing brain is ready for information and it's not getting it, you're going to get this nystagmus, and that's very clear with cone dystrophy. Now, things can develop later, like we know with genetics, it could be progressive later in life. You may not get the nystagmus then, but they will develop nystagmus later, with time, with progressive vision loss. Okay. So going back to your question, sorry, I don't think I got. So vision, acuity, color vision, and then looking at the back of the eye will tell me quite a bit. Imaging it in terms of OCT, which I'm sure, did you have any conversations about OCT yet? Optical coherence tomography. So it's a way to image the retina.
We could have a talk sometime later on OCT for neurologists, but
sure.
We only get a report. Nobody, the ophthalmologist often doesn't give any typed report. So we could have one on perimetry and OCT for neurologists together. So,
You're asking me that I should get that done?
Yes, a simplified OCT and perimetry for neurologists. Huh?
Of course, I'll do that. That's no problem. So, but OCT is...
We are running behind time. Maybe Chandrasekhar can ask one or two more questions.
I'm sorry.
Yeah, I think we are done. We are done with the most of the questions.
Okay.
So I think thank you, Veeral. It was a great session, and we'll see you again with another talk and further causes of diplopia, and with some interesting cases and explanations, some videos. That will be great.
Okay, great.
Thank you.
Thanks.
Thank you.
Thank you.
Have a good night. Bye.
Yeah, have a good. Thank you. Have a good day, guys. Bye.
Yeah.